Good afternoon, everyone. So for our topic this afternoon, this is the most common type of dementia. So we're tackling about Alzheimer's disease. Okay, when you see dementia, okay, this is a collective term that is used to describe various symptoms of cognitive decline that is secondary to an underlying disorder. Okay, so Alzheimer is a type of dementia. Okay, and never interchange the two terminology. So these are the famous personality who suffered from dementia, okay, or Alzheimer's disease. Okay, so we have Albert Einstein. Okay, the image number two. Number three, we have Pope John Paul, and so on and so forth. Okay, so what does it mean to us? Okay, so Alzheimer's disease, it doesn't just target one group of people. Okay, even if you're rich or poor, famous or not, okay, dementia can strike to everyone. So, Alzheimer's disease, this is the most common and important degenerative disease of the brain. Okay, these are the important examination that we perform if we are considering a neurodegenerative condition. So we have to assess their level of consciousness. Okay, however, most patients with Alzheimer's disease, okay, their level of alertness, they are usually awake. Okay, and um, until you perform other examination like their attention, okay, they are unable to focus to focus on a specific task. Of course, language is also part of the examination, so it's important. That is why you should know the handedness of your patient. Okay. Also note for the spontaneous speech. Okay, if they are unable to engage on a spontaneous conversation or comprehension, this is the ability to understand spoken language. Okay, and you also ask them to repeat certain words. Okay, and also ask them to write and spell certain term. Okay, so most of patients with Alzheimer's disease, they have impaired immediate recall. Okay, so I'll explain to you later on why. Okay, and it's also important to assess their orientation to time, place, and person. Okay, and also their remote memory. Okay, higher cognitive function. These are information that a person has stored in memory regarding place and things. Okay, so this is the fund of general knowledge. Okay, so the fund of general knowledge, this one increases with higher educational attainment. Okay, so you ask them who's the current president. Okay, how about proverb of interpretation? Okay, this one requires understanding of an abstract meaning of phrases. Okay, so for example, um, um, you give them example to interpret a certain proverb like it's no use crying over a spilled milk. Okay, and or in Tagalog, how about in Tagalog? So anuhin mo ang damo kung patay na ang kabayo. No? So their answer should be correct. Okay. Constructional ability. So you ask them to copy different shapes, figures. Okay, simple shape lang, no? So this will test their visual spatial orientation. So the incidence of Alzheimer's disease, as you can see, it increases as the age group also increases. Okay, and the prevalence is higher in women. Why? Okay, because women has a longer half life. Not half life. Sorry, has a longer lifespan compared to male. Okay, and the cells that are dying in the brain is faster in women. Well, according to some studies. Okay. So these are the different risk factors for developing Alzheimer's disease. Okay, we have birth order, advanced maternal age, family history of Down syndrome, okay, and head injury. So head injury, example for boxers, especially repeated head injury, um, sometimes it confers an increase later in life. Okay, low educational attainment, of course, they have a poor cognitive reserve. Familial occurrence for Alzheimer's disease is also well established. In less than 1% of such cases, there is a dominant inheritance pattern with a high degree of penetrance, and usually the appearance of the disease is at a younger age. So these are the clinical feature of Alzheimer's disease. The onset is always, remember, the onset is always insidious. Okay, neither the family nor the patient can actually notice the the symptoms of dementia. Okay, the symptoms of forgetfulness. So the major symptoms is a gradual development of forgetfulness. Small day-to-day happening are not remembered. Okay, so usually their possessions are usually misplaced, and questions are repeated several times. No, makulit sila. And this the Ribot law of memory. Okay, this is it explains why the remote memories are preserved and the recent ones lost in patients with dementia. Okay, so this is a simple diagram explaining the Ribot law of memory. Okay, so look first to the image on your left. Okay, for example, if you encounter a new information, okay, it will go immediately to your neocortex. Okay, that is represented by the red dots. Okay, however, the connection there is very weak, and it is reliant on its connection to the medial temporal hippocampal system. Okay, whenever you need to retrieve that memory, okay, you need the medial temporal hippocampal system. Okay, however, because of some intrinsic process within your neocortex, okay, there's a strengthening in connection between this memory trace. Okay, so since it is already consolidated, the memory can now be retrieved without the help of your medial temporal hippocampal system. Okay, this is this is the reason why patient with Alzheimer's disease, the immediate recall is abnormal, is impaired, no? Because usually there's an atrophy of your medial temporal hippocampal system, okay? In that certain part of the brain, okay? Even if you ask them, ano yung kinain nila this breakfast, hindi nila maalala. Okay? Pero but if you ask them, okay, what's the name of the eldest sibling, they can answer that. Okay. Amnesia is one of the once the memory disorder becomes pronounced, other cognitive failure, okay, is failure is so once in one of the clinical symptoms of Alzheimer's disease is amnesia. And once this becomes pronounced, other cognitive failure becomes increasingly apparent. Okay, so they can have aphasia. Initially the vocabulary becomes restricted. Okay, and the form of aphasia is an expressive one. Okay, they cannot follow a complicated task. They can have also difficulty naming. Okay, anomia. Okay, and difficulty in arithmetic skills. Okay, that's why they cannot manage their banking financial statement, okay, balancing checkbooks and prices, okay, because they have acalculia and dyscalculia. And they also experience impaired visual spatial orientation, wherein if you they have difficulty in parking their cars, okay. This is the individual has a difficulty in performing motor planning, okay, to perform a specific task, okay, or a movement when being asked, okay, provided that the request or a command is understood and the individual is willing to perform that specific task. Okay? So they usually becomes lost. Okay? Mabilis silang ma-disorient. Okay? Okay? And also apraxia. Okay? So yun nga, no? They have difficulty in performing tasks. So only the habitual and virtually automatic actions are preserved. So ano ba yung mga habitual, virtually automatic action? Using of spoon, fork, no? Usually preserve naman yan. But at the later part of the disease, okay, as the Alzheimer's disease advances, okay, pati yung use of spoon and fork, mawawala din. Okay? Psychiatric signs and symptoms such as paranoid delusion, okay, sometimes they are jealous, okay, and they have tendency to become paranoid. Their possession are being their possessions are being stolen. Okay, hallucination, okay, in the form of auditory and visual, but most common ang hallucination in patient with Alzheimer's disease is visual form. Okay, is inhibited behavior such as sexual indiscretion and mood and behavior problem. Okay, they have indifferences, okay, egocentric, increased or decreased appetite. Well, convulsions is very rare. It usually occurs around up to 5%, but in the later course of the illness. So remember that your cortical and your corticospinal and your corticosensory function, as well as your visual acuity, remain intact. Okay, no problem also in sensory and balance. Okay, however, in advanced stages, they can have Parkinsonian feature that will manifest with akinesia, rigidity, tremor, difficulty in locomotion, and unsteadiness. Okay, since it affects the entire cerebral cortex, okay, the primitive reflexes also may show up. Okay, because in normal adult, these reflexes, the frontal release sign and your primitive reflexes are usually inhibited because your brain is developed. Okay, in patients with Alzheimer's disease, okay, they can have grasp and sucking reflexes. Usually nakikita ito sa bata, right, in pediatric group, okay, because brain nila is not yet developed. Well, according to the National Institute of Neurologic and Communicative Disorder and Stroke, as well as the Alzheimer's Disease and related disorder, related disease and association, so they propose a 5 criteria in order to diagnose a patient with Alzheimer's disease. Okay, so you need to fulfill these 5 criteria. The first one is that the dementia is defined by clinical examination. Okay, so we make use of certain objective type of questionnaire like your mini mental status scale, okay, and the blessed dementia scale or similar to MSE. And remember, before you administer this test, you should always ask for the educational attainment, no? Because there are some score adjustment, no, in those with no educational attainment. Okay, and patient should be older than 40 years old. Okay, remember, you cannot diagnose a patient with Alzheimer's disease, no, pag 25 years old. So 25 years old with sudden onset of loss of consciousness, you cannot think of an Alzheimer's disease. Remember, Alzheimer's disease, okay, this is common among elder population, okay, older population. And the third criteria is there is a deficit of 2 or more areas of cognition and progressive worsening of memory and other cognitive functions such as your language, perception, and motor skills. Okay, and number 4, there should be an absence of disturbed consciousness. Okay, so yan, no, sabi ko sa inyo in my previous slide that most of patients, no, all of them, no, are the level of consciousness, they are alert and awake. And there are the last criteria is the exclusion of other brain disease, okay? Because there are a lot of brain diseases, okay, that may produce symptoms of dementia, okay? Mga secondary cause of dementia. So using this above criteria, so the correct diagnosis is achieved in more than 85% of patient of so 85% ang kanyang the reliability of this criteria is 85% of most patients that has fulfilled this criteria. Okay. So this is an example of a patient with Alzheimer's disease. Okay, you can see hindi niya maboton yung ano niya, yung kanyang polo. Okay. And if you ask the patient to do a clock, okay? So part of our examination, okay, is a clock drawing test, okay? So this is a nonverbal screening tool in which the patient is asked to draw a clock, okay? So iba-iba yung scoring, but the most popular scoring that we use is the 4-point clock drawing test, okay? So how do we score them? Okay, the placement of numbers, okay, around the circle, okay, the numerical sequence, okay, the circle and the placement of the hands, okay, and the correct number of the hands, and the correct the hands and the correct placement of the hours and second, okay. The patient should the any patient who scored 3 and below, okay, so they can be labeled that we can tell that this patient has an impaired executive function, okay. So the clock drawing test is mainly for executive function, because the executive function, okay, is if it is impaired in patient with Alzheimer's disease, that is the most disabling part of the disease, okay. So you can also ask the patient to copy a model. Kanya yung flower, di niya makaya, no? Okay. And there can be memory, personality changes, okay, loss of social and occupational skills, okay. So in advanced stages, okay, this is the gross pathology. There's a diffusely atrophied brain, okay, reduced by 20% or more. And look at the cerebral convolution, they are narrowed, okay, and the sulci are widened. And as you can see, the third and the lateral ventricle are symmetrically enlarged to a varying degree, okay. So we have 3 characteristic pathologic findings in Alzheimer's disease, okay, which we can appreciate, okay, in the microscope in a patient with Alzheimer's disease. First is we have the neurofibrillary tangles, okay, this is located within the neuronal cytoplasm. This is a thick fiber-like strand of silver staining material, okay, and it's composed of hyperphosphorylated form of microtubular tau, okay. Early in the disease, okay, most of the NFT is pronounced in the layer 2 of the entorhinal cortex. The second one is the Neurofibrillar Degeneration, wherein there is formation of clump masses of neurofibrils within the cytoplasm, okay, and it is seen in Alzheimer's disease, okay. Okay, we have also the neuritic plaque. Okay, this is a spherical deposit of protein amyloid surrounded by degenerating nerve terminal. Okay. And last, we have the granulovascular degeneration. Okay, this is most evident in the pyramidal layer of the hippocampus. So the GVD, these are membrane-bound vascular structure, okay, harboring a dense core that accumulate in the hippocampal area. Well, this is the image of your neurofibrillary degeneration. Okay, remember that it is composed, okay, it consists of hyperphosphorylated tau proteins, okay, whereas your neuritic plaques, okay, which is consists of your beta amyloid peptide, okay, surrounded by your dystrophic neurites. Okay, so the image on your left is is a healthy neuron, okay, in patients with Alzheimer's disease. You can appreciate extraneuronal, the amyloid plaques, okay, and inside the cytoplasm is the neurofibrillary tangles. And there's also Lewy body, okay, this is not found in Alzheimer's disease, but in other form of dementia, such as your frontotemporal LBD, Lewy body dementia. Okay, so this is a cytoplasm of pigmented dopaminergic neurons of the substantia nigra pars compacta. Okay, so in patient with Parkinson, you can also observe this one. Okay, located in the cytoplasm, where you can appreciate accumulation of your alpha synuclein. Okay, so Pick's body, okay, but seen in the pyramidal neurons of the hippocampus. Okay, the stain that we use is the Bodian silver, and this is seen in patient with FTD or frontotemporal dementia. Okay, so this is a good table, okay, of different neuronal inclusion. So when you have inclusion, meaning that is a certain pathologic reaction of the brain, of the neuron secondary to an injury. Okay, so it is important to know their location, if it's located in the cytoplasm or outside the cells or in the nucleus. Okay, and their composition. Okay, so your neurofibrillary tangle is composed of tau, okay, and it is characteristic of characteristic condition is the Alzheimer's disease. Okay, your Pick's body also with tau. Okay, sa Pick's disease din yan. So again, the Lewy body, okay, it's located in cytoplasm. It is not there's no amyloid in your Lewy body, but there's an alpha synuclein, where you can see this in patients with Parkinson's disease and dementia with Lewy body. Okay. Remember that your neurofibrillary tangles and the quantitative neuronal loss are the ones that correlates best with the severity of dementia. Okay. So for the pathogenesis, the tubulin-associated unit or tau, this is a cytoskeletal protein, okay, promoting assembly of microtubules, and this participates in synaptic plasticity. So in Alzheimer's disease, in progressive supranuclear palsy and FTD, okay, or frontotemporal dementia, tau is hyperphosphorylated and usually they aggregates. So this results to overloading of the pericardia, okay, comprising with paired helical filaments comprising neurofibrillary tangles. So your amyloid protein, okay, specifically the beta amyloid protein, okay, a small portion of the amyloid precursor protein or APP, okay, which is a normal transmembrane neuronal protein. There's a neuroprotectant role of this one, so it reduces calcium, reduces glutamate, okay. So it is neuroprotectant, no? So, and it promotes myelination when the neurons are injured. Okay? Remember that the elevation of the level of the amyloid beta 42 leads to aggregation of your amyloid. And this will in turn result to neuronal toxicity. So the amyloid protein, okay, the beta amyloid protein, okay, so the gene that codes for your amyloid precursor protein is located in the chromosome 21. Kaya the Down syndrome and Alzheimer's disease, they are closely related condition. Okay, however, in Down syndrome, the excess production of your APP will cause the further the excessive production of your APP, okay, will result to increased number of your amyloid beta 42. Okay, and it is caused by triplication of the long arm of the chromosome 21. Okay, so remember that your presenilin 1 and presenilin 2, okay, this is a subcomponent of the gamma secretase used to cleave the APP or the amyloid precursor protein. Okay, mutation of this protein will result to an increased level of your amyloid, beta amyloid protein 42. Okay, and again, this is neurotoxic. How about apolipoprotein E? So this is a regulator of lipid metabolism that has an affinity to beta amyloid in patients with Alzheimer's plaques. Okay, the isoform is because there's a lot of isoform of your ApoE. But remember the ApoE4. So this is the it increases it causes tripling the risk of developing of sporadic Alzheimer's disease. Okay, whereas I think the ApoE2 is somewhat protective. Okay, if you have a lot of ApoE2 in your brain, that's protective for Alzheimer's disease. Okay, so remember that your ApoE4, this is the same allele that contributes to the elevation of your LDL in the serum. Okay, so again, to further explain to you, look, okay, here, look at the figure on your left first. Okay, so in a normal, during a normal metabolism, okay, so your APP protein is cleaved by either by your alpha or your beta secretase. Okay, so the product of this reaction is then cleaved by your gamma secretase and other caspases. Okay, and this will and the sequential cleavage by the alpha and gamma products, okay, will result to the generation of synapses. This will cause apoptosis, okay, normal cell death. Okay, this is not neurotoxic. Okay, however, okay, if the cleavage, okay, if cleavage by the beta secretase, okay, results usually in 40 amino acid product. Okay, this 40 amino acid product, okay, if further cleaved by your gamma secretase, okay, will result also to production of your beta amyloid 42. Okay, and again the ApoE, okay, especially the ApoE4, this will promote fibrillogenesis that will result to amyloid accumulation and that will result to amyloid neurotoxicity. Okay, so this is the pathogenesis why there's an accumulation of amyloid. Okay, so the ratio of this is the image on your left. Okay, so this is this is the model of Alzheimer's disease. Okay, so the ratio of your beta amyloid 42, okay, to 40, okay, this is critical to the neuronal toxicity of amyloidogenesis, okay, to the formation of your amyloid. Okay, so neurotransmitter abnormalities, okay, so acetylcholine in hippocampus and neocortex are markedly reduced. Okay, reduced concentration of some amino acids such as your glutamate and several neuropeptide such as your substance P, somatostatin and cholecystokinin. So these are the diagnostic studies that you need to know. Okay, neuroimaging. Okay, in the form of CT scan or MRI. Okay, this is to include we perform neuroimaging. This is to exclude other cause of dementia. Okay, such as tumor, subdural hematoma, stroke, hydrocephalus. Okay, so what is important, slice or view that you need to look at, okay, is the coronal view. Okay, because you can see you can see there in the coronal view the atrophy of the temporal lobe. Okay, where your hippocampal system is located. Okay, EEG. Okay, usually it will give you a result of diffuse slowing. Okay, CSF is not actually a routine in Alzheimer's, but normally it will show slight protein elevation. Okay? Studies of the cerebral blood flow using SPEC or PET may show diminished activity in the parietal association regions, okay, and your medial temporal lobe. And of course, the different neuropsychological tests. No? We have the mini mental status exam. We have the Montreal cognitive assessment. Uh, Montreal Cognitive Assessment Test or MOCA-P. Okay. How about plaque drawing test? Marami. Actually, there's a lot of neuropsychological tests. Okay. We have frontal battery tests also. So compared to the normal brain on your right, okay, you you can appreciate a generalized atrophy of the brain in patients with Alzheimer's disease, and this corresponds to volume loss, okay, as well as neuronal loss. Okay, here we can also appreciate, okay, enlarged ventricles, okay, compared to this one. Okay, so this is the coronal view. As you can see here, the hippocampal area is atrophied, okay, compared to this one. So this is a coronal view of your brain. So how about other types of dementia? Okay, so we have frontotemporal dementia. Okay, this is Pick's disease. So because the um, neuropathologic findings, usually they have Pick's bodies. Okay, there's a degeneration of the frontal and your temporal lobe. As you can see here in the gross specimen, the frontal lobe is atrophied as well as the temporal area. Okay, yung parietal and occipital, normal siya. Okay, there are two types. Okay, we have behavioral and language. Okay, the behavioral variant. Okay, um, they may present with personality and related abnormalities, and this includes, okay, apathy, disinhibition, perseveration, poor judgment, okay, and general disengagement. Okay, language. Okay, we have primary progressive aphasia. Okay, so this affects the left temporal also and your frontal lobe. Okay, we have three types. We have progressive non-fluent, we have semantic, and the logophonic aphasia. Pag sinabing primary progressive, okay, the patient initially speaks less, okay, they have word finding difficulty, okay, but the language structure is intact, okay. Pag sinabi namang semantic dementia, okay, it is characterized by early difficulty naming items, people, words, okay. And the third type is the logophonic aphasia. This shares most aspect of the non-fluent aphasia, but in which the meaning of the word is usually retained. Okay. Next is posterior cortical atrophy. Okay, the average onset is 60 years old. Okay, and the initial manifestation, there's a progressive loss of ability to interpret visual information. Okay, there's a severe visuospatial difficulty with relative preservation of memory. No, so you can see here the MRI of a patient with posterior cortical atrophy, the occipital area. Okay, kita nyo, in relation to your frontal lobe, mas maliit yung occipital lobe nyo na nag-atrophy. Okay, so atrophy will result to dyslexia, okay, depth of perception, okay, they can have prosopagnosia, inability to recognize faces, achromatopsia, okay. So this is the most common pathologic report has been a characteristic of Alzheimer's disease. So ito rin is, they also have hyperphosphorylated tau. No? May mga amyloids deposit din in patient with posterior cortical atrophy. Next is the Lewy body dementia. Okay, so this is the second most common frequent pathologic diagnosis of globally demented patient. Okay, the first one is Alzheimer's disease. So the pathologic changes usually there's a diffuse involvement of the cortical neurons of Lewy body inclusion. Okay, and there is of course, since this is a synucleopathy, okay, there's an absence of neurofibrillary tangle. Okay, so again, the Lewy body consists of your alpha-synuclein. This is the main component of your Lewy body, and this is also seen in patients with Parkinson's disease. So the clinical feature, there's a Parkinsonian feature, dementia, and episodic delirium. Okay? So hindi lahat ng may cognitive decline, okay, you can label them as Alzheimer. Okay? That's why it is very your history is very critical in making diagnosis of different neurodegenerative disorder. Okay, so baka nag-start siya with Parkinson, then dementia, okay, nagkaroon ng delirium, okay, most likely Lewy body dementia. Okay, and these are the different before you make a diagnosis of Alzheimer's disease, you should always consider treatable form of dementia. Okay, for example, if this one is normal pressure hydrocephalus. Okay, so however, yung mga normal pressure hydrocephalus, they have urinary incontinence. Okay, aside from dementia, meron silang urinary incontinence and bilateral lower extremity weakness. Okay, difficulty ambulation. So, and pwede rin chronic subdural hematoma. There's history of trauma. Okay? AIDS dementia complex. Okay? Also paraneoplastic limbic encephalitis. Okay? So one of the differential diagnoses is nutritional deficiency, such as your vitamin B12 deficiency. Okay? Thiamine-Wernicke-Korsakoff syndrome. So, diba? May mga amnesic episodes sila. And of course, chronic drug intoxication like your alcohol or sedative, no? Pwede ring withdrawal. Okay? Multiple cerebral infarction, no? Kung mga previous strokes, previous number of strokes, later on their recovery, they will develop dementia. So ang tawag dun is vascular dementia. Okay? So the other differential diagnoses, endocrine and metabolic disorders, okay, Hashimoto encephalopathy, okay, neurosyphilis in later stages, okay, chronic meningitis, okay, frontal and temporal lobe tumor, they may also simulate the symptoms of dementia, okay, cerebral vasculitis, okay, sarcoidosis, Whipple's disease, multiple sclerosis, as well as pseudodementia of depression. Okay, pseudodementia of depression, this is due to polypharmacy in elderly. No? So I think, how about treatment? No? So again, you consider this diagnosis before making a complete diagnosis of Alzheimer's disease. Okay, so let's now proceed with treatment. Okay, so for treatment, well, we only have medical treatment for Alzheimer's disease. You need to explain to the patient that it will not reverse the cognitive decline, okay? But it will just retard the progression of the deterioration of the cognitive function, okay? Kasi baka ang akala nila babalik sa dati, no? This is a progressive disease, okay? So the first group are the acetylcholinesterase inhibitors. Okay, we have the Nepisil. Okay, this binds and reversibly inactivates the cholinesterase. Okay, so this will result to inhibition of the hydrolysis of your acetylcholine. Okay, so mas marami ka ng acetylcholine in your synapses. Okay, NMDA antagonist. Okay, memantine. Okay. Your memantine, so this is low affinity, voltage dependent, and competitive antagonist at glutaminergic NMDA receptor. Diba? Maraming receptor ang glutamate, but this one targets your NMDA. Symptomatic drugs, neuroleptics, if there's a behavioral problem, okay, behavioral syndrome, okay, may mga hallucination, you can give antipsychotic, but remember, never give those typical ones. You can give a typical antipsychotic, may mga olanzapine, okay? Because those typical drugs may result to Parkinsonism, okay? Antidepressant, you can also give antidepressant, sleep medication, okay, in the form of low-dose benzodiazepine, okay? Well, future trials, wala pa naman. This immunization against amyloid, well, this is understudied and not yet tested on humans. Okay? So these are the treatment for your Alzheimer's disease. Okay? So I think this is my final slide. Okay? If you have any question, you can ask me after this video. Okay? Thank you. Thank you very much.